So for those that I have not met yet, my name is Rich Pizzillo. I am the Executive Director of the New England Hemophilia Association. And again, we're so excited. This is our third annual VWD Retreat. And this retreat was created based on feedback, feedback from the community that we needed to have education specifically for VWD. So we have a great lineup today. Of course, this is not what we were originally expecting, just like many things this year. This retreat was originally planned for July in Providence, Rhode Island, but we're really excited to connect virtually. There are many of you from New England, many of you from outside of New England, and technology like this gives an opportunity to all connect together. So I just want to go through a couple of the agenda items before we get into the keynote. So this morning, we're going to have introductions, which is right now. Then we're going to have our keynote presentation, which we're super pumped about at around 9:10. Then we go into our breakout sessions. You received an email from Sarah about the 3 breakout sessions that we're offering. If you didn't have a chance to select it, no worries, we got your back. You'll be able to put them in the chat and Sarah will magically assign you to breakouts. If you've never done it before, it's super fun and magical. Then we'll have wrap sessions. If you've never been in a wrap session before, they're meant to be confidential in smaller groups so that you can have a chance to be with each other. A couple of things. You should have received in the mail a packet from us. The packet included a gift card for breakfast this morning on NEHA, whether you got Dunkin' Donuts, Honeydew, whatever fits your boat. Thank you to those that donated their breakfast gift cards back to us. We really appreciate that as well. So let me just share my screen and we will get going here. This photo, I love, it's from last year. It's a group shot of, again, the von Willebrand's retreat, which was up in Portsmouth, New Hampshire. So this retreat wouldn't be possible if it wasn't for our generous sponsors, CSL Behring, the Hemophilia Federation of America, Octapharma, and Takeda. Thank you very much for making this retreat possible. So with that said, if you've never done this before, I ask you to grab your phone. If you don't have your phone near you, please go grab it. It's been a NEHA tradition during these virtual programming to do live polling. If you haven't seen live polling before, it's super cool, where you text what's on the screen and it populates a graph. We don't record your number, you won't get spammed. We actually can't track where everything's coming from and it's all anonymous. So I'm gonna stop sharing my screen and share another screen and we will get into the live polling. All right, so the first question we're gonna do is kind of a fun question. What is your favorite holiday drink? So you're going to text 781-412-7971. And number 1 is eggnog. Number 2 is apple cider. Number 3 is hot chocolate. Number 4 is mulled wine. Number 5 is none of the above. I always love seeing this because you think eggnog was in the lead, but then you have hot chocolate and mulled wine. It's like kind of like the Kentucky Derby. Who will be ahead here? So for those on the phone, it looks like eggnog overwhelmingly is about 40%, and then followed by hot chocolate and mulled wine with a solid second. Oh no, apple cider's trying to come ahead, but it looks like hot chocolate is definitely kind of as the second place. Awesome. So let's go to the next question. What's your favorite holiday movie? I know many of you have put holiday decorations up already. So this will create a word cloud and you'll see it come up on the screen. So far we have Elf, White Christmas. If something gets larger, just like Elf does, it means multiple people are saying it. So we have Charlie Brown Christmas, Elf, White Christmas, A Christmas Story, classic. Just don't put your tongue on any pole when it gets cold because we're not going to help you. And you have a bleeding disorder, so that's not good. Years Without a Santa Claus, Miracle on 34th Street, classic show there. It's a Wonderful Life. That is a tradition to watch that on Thanksgiving, so awesome. Grinch, great. All right, let's go to the next one. Now we're going to go into VWD. Have you been to a NEHA VWD retreat before? Text 1, yes. Text 2, no. Text 3, I don't know. It's 2020. I can't remember anything. So we'll see what it is. So far for those on the phone, about 70% said yes, they've been to a VWD retreat, a NEHA VWD retreat before. About 30% said they haven't, and 3 can't remember anything because it's 2020, which will get you, which you have a get out of jail free card for this year that you can't remember that. But this is great. About 30% of you have not been to the retreat before. All right. So this is what type of VWD do you or a loved one have? So text 1 for type A, text 2 for type 2, text 3 for type 2A, 4 for 2B, 5 for type 2M, 6 for type 2N, 3 for type 3, and 8, I have a different bleeding disorder. So far it looks like type 2 has about 40%, followed by type 2A. And then there's a smattering of just about all of the other conditions. There we go, type 2N has some love there. So 35% has type 1A, followed by type 2, and then type 2B has the next. All right, this is the last question. What do you hope to gain from participating in this virtual retreat? This will populate as more letters. There's no right or wrong answer for this. Totally up to you for what you say. So knowledge, new information, connection, information, treatment options, resources, new information, friends, nice, learn about changes, resources, more not, oh, whoever used the emoji, bonus points. I do not know how to do that. So kudos there, friends, resources, need information. All right, so I'm gonna stop. Dr. Connell, someone said, I am here to fangirl Dr. C. So you totally have a fan out there. Actually, you have many, and I am definitely one of your fangirls. All right, so with that said, I am going to stop sharing my screen, and I am going to spotlight, or Sarah or Michael, if you could spotlight Dr. Connell and Caitlin, I'm going to introduce the both of them. So Dr. Connell is from Brigham and Women's, and Caitlin Moncrief is from the Rhode Island Hemostasis and Thrombosis Center. Caitlin helped to create the VWD retreat back 3 years ago, and has been essential as these retreats have been put on. And Dr. Connell presented last year and had overwhelmingly not just positive feedback, but many of you that saw his presentation absolutely loved it. So with that, today we Dr. Connell will be presenting. Caitlin will be monitoring the chat and moderating. So if you have a question, feel free to put it in the chat. Many of you have submitted questions ahead of time. If you're not comfortable with everyone seeing it, you could private message Caitlin, and we'll get to those at the end. So the keynote today is guidelines on the diagnosis and management of VWD, an update for patients and families. So with that said, Dr. Connell, I'm going to turn it over to you, and you can share your screen.
Great, thank you. Thank you, Rich, and thank you, Caitlin, for joining me today for this. And let me get the slides going. So hopefully everybody should be able to see my title screen at this point. And so thank you, to all of you for inviting me back to talk about this. I'm very excited. I think I gave you all a little bit of a preview last year that these guidelines are coming, and a publication that had just come out related to work that fed into the guidelines. So this morning, I'm going to talk primarily about some background on VWD. Some of that you'll have seen last year, but I want to set the stage for our discussion and really dive into the guidelines. This is information that was put out for public comment earlier this year and has been presented at a couple of the professional society meetings. So some of you that may have attended those as patients through the virtual summit of WFH or the ISTH virtual Congress got to see little pieces of this, and so we're excited to share. And then I'm going to go through some questions. Thank you for all of you who submitted questions in advance. We do have those. I'm going to try to go through them as best I can. I don't have answers for everything, and I'll be honest about that. And then we'll have the opportunity to go through questions, and Caitlin's going to help me kind of moderate that and help me out with answering a lot of those. So again, kind of thinking back, I love history and history of medicine. So why do we call this von Willebrand disease? Well, it really started with Erik von Willebrand, this physician who described what was then called hereditary pseudohemophilia. And so it seemed like hemophilia. It was not quite the same because it happened in women as also men, but it was definitely hereditary. So that's how it got its name. And it was really on this island here between Finland and Sweden that the first kind of family was described. And when the papers came out, here's what they originally looked like in the literature: hereditary pseudohemophilia. And this has been cited thousands of times in all of the work since then as the first description of von Willebrand disease. And if you dive into these descriptions, what you'll see, this was the family, the pedigree of the family that he first described. And as you can see, there is definitely a genetic component because multiple family members were affected, one in every generation, at least one in every generation. But as you can see, not everyone was affected. So that really started to give an idea to how this was genetically inherited. And I love this photo. I showed it last year. And you'll see here, this is Hjordis. She was the first patient to be described with von Willebrand disease. She was 5 years old, and she had 3 of her sisters actually die before the age of 4 with bleeding from various sites. And 1 sister was also affected. Everybody else in the family, parents had mild bleeding, and the bleeding was usually from skin, mucous membranes. There wasn't a lot of hemorrhage into joints and deep tissues, but by the time that they actually published Hjordis's case in the family, Greta had passed away of gastrointestinal bleeding, and Hjordis ended up dying with her 4th menstrual period. So clearly, this is a very severe form of VWD compared to what many patients experience, but it really speaks to the variability in the types of bleeding that many people living with VWD have. So why did Hjordis and her family have bleeding? Well, we now know it's an inherited loss of a key protein in the clotting system. We call that protein von Willebrand factor. When I talk to my own patients and talk about bleeding, I say, think of the protein in an egg white. It's clear and liquid. You apply some heat and that protein gets triggered to turn solid. Obviously, what's going on in our blood is much more complex than that, but it gives a good analogy to think about why these proteins are such a key component. And what is von Willebrand factor? Well, it has a couple different jobs. It stops bleeding by forming clots and has a couple of main functions. It helps blood cells called platelets stick to each other. It protects clotting factor 8, which is the main protein deficit in hemophilia A. And so that's why it seems very much like hemophilia in some forms, because not only is there low von Willebrand factor, but also a low clotting factor 8. And we also think that it has a lot of other effects. One of my favorite papers in the literature recently is one called Von Willebrand Factor, the Jedi Knight of the Bloodstream. And it talks about all the different effects that von Willebrand factor has to be able to keep blood flowing as it should and also help with things like wound healing. So if you don't have enough von Willebrand factor, or if it doesn't work right, we call that von Willebrand disease, or VWD for short. And we know that it's the world's most common inherited bleeding disorder, but it's still considered a rare disease. And so this is one of those challenges. It is not something that people will come across commonly in general practice, but it is something that needs to be thought of every time you're evaluating somebody for bleeding. This was another chart that I showed last year, and I also like this. Evan Sadler, who had done a lot of the work, was considered by many to be a father of modern VWF research. And a lot of what we do now is based on the work that Evan has done. Evan was part of our guideline panel and sadly passed away during the development of the guidelines, but was one of his last publications was our scoping survey for the VWD guidelines. And what this shows is the difficulty that we have with management and understanding diagnosis. It's all in one graph here. So if you have, this is how much von Willebrand factor you have in the blood, and then this is a risk of different things happening. So if you have less protein, you're more likely to be found to have a specific genetic mutation and more likely to have bleeding. Most people sit with a von Willebrand factor level of around 100%. The more von Willebrand factor you have in circulation, the higher the risk of clotting. So, you know, some may say, well, why not just give everybody lots and lots of von Willebrand factor so that you can then make sure that nobody bleeds? Well, it's always trying to find this balance between reducing the risk of bleeding, not increasing the risk of clotting. And so this is an important piece to think about. Our guidelines, this is a collaboration across 4 large organizations. This is the first time these many organizations have ever come together to develop guidelines. And why did we do this? Well, these 4 organizations have a commitment to improving the quality of life for those living with VWD. And by sharing our expertise and resources, you can ensure quality and credibility. But also, once the guideline is published, you have to get it out there into clinical practice. You need to implement it. You need to understand what are the barriers and how do you overcome those barriers. And we really felt that patient input was important. Many guidelines don't include patients, and it's a bit of a disservice. So we had patients who served as members of the panels. We surveyed several hundred people globally, and this was published in Hemophilia, and we talked about last year, to understand what were the key topics. And we also opened it to public comment earlier this year, and all 4 of the organizations really made a push for patients to provide input. ASH has done a lot of guidelines, and I'm proud to say that this guideline had the most number of patient comments of any guideline that they have ever published. So that was very exciting for us. And what were the objectives? Well, we wanted to facilitate clinical decision-making, to contribute to better health outcomes, increase access to appropriate diagnostic testing and therapies, increase quality of life and health equity, making sure that everyone has access to treatment that needs treatment. And also because we understand that there's a lot of areas for research, what were going to be the key priorities for research over the next 5 to 10 years. And guidelines can then guide healthcare providers, patients, insurance companies, stakeholders, policymakers to priority focus areas in VWD. I'll talk a little bit about the research that's come out of it, but what is very exciting is we're actually having a conversation with the group that handles diagnosis codes to try to make sure that we have appropriate diagnosis codes on the billing and payment side to ensure that people can get access. And we're having discussions about certain tests that aren't as widely available and see if we can get help through regulatory agencies such as the FDA to be able to make sure that there is access to appropriate testing. There were 2 panels, one focused on diagnosis, one focused on management, with a variety of individuals and viewpoints. And the panelists came from 10 countries across 4 continents. So this is truly an international effort. We had hematologists, experts in how to do the literature search and combine the data to really analyze it. We included gynecologists, pediatricians, the patient representatives, And when we look at the patient representatives, we had 7 total across the 2 panels, full voting members, diverse with respect to gender, the type of VWD they had, the severity of their disease and their disease experiences. So again, this is the first time that this has been done in VWD. We were also very committed to conflict of interest disclosure and management to make sure that these would be widely accepted and there would be no concerns of undue influence from certain groups. When we talk about how do we develop it, well, we first came up with about 10 to 20 clinically relevant questions, narrowed it down. Each panel got about 10 questions, so we came up with 20 total. We then went through an evidence summary. So PICO stands for Patient Group of Interest, Intervention of Interest, Comparison of Treatment, for instance, and Outcomes. So it might say, you know, in a patient with type 3 VWD with severe and frequent bleeds, should we provide prophylaxis or no prophylaxis to reduce bleeding? So that gives you PICO. And then systematic reviews are a standard way to search the thousands and thousands of papers that have been published about VWD, pull the data out of it, and then move it forward into an evidence summary. We then go through a standard process where we take the evidence, look at resource use, feasibility, acceptability, layer in patient preferences and values from our patient panelists, and come up with what are the recommendations based on all of this. And so all of this is published with the guideline. The guideline document in Word format, I can tell you, runs about 83 pages for each document. But there's about 300 pages worth of detailed information for anybody who wants to go in there and see how did we get from these questions all the way to recommendations. And you can see this at each step of the way. When we come out of the guideline, you're going to see these in what we're talking about. We also talk about how patients and clinicians should use these recommendations. So we make recommendations, we'll say this is a strong or a conditional recommendation. So this will say we recommend or we suggest. And what does this mean? For patients, when we give it a strong recommendation, most individuals would want this intervention. So an example of this might be in a patient who has pneumonia with a confirmed chest x-ray, you know, that we recommend treatment with antibiotics. Whereas a conditional recommendation might be for a patient who is at risk of bleeding with VWD, we suggest consideration of an assessment of factor levels at that time. It may not be that critical at that specific moment, but it's something that should be brought up in conversation. For clinicians, we think about this, most individuals should receive it. And this is where we make a specific call out to shared decision making. These are the gray zone areas. And you'll see that because of the data we have a lot of gray zones in VWD. And that's why you see variability in the way that you and your families may be managed based on specific circumstances. We took a high resource setting. We wanted to say that this should be the global standard to shoot for. We know that we can't get this in every single area of the world, but what might be optimal? And this allows us to then go through advocacy work. Adolpment is a guideline term that combines adaption, adoption, and de novo development. So we know that if we do an adolpment effort, say in Central America, we have to adapt to what are the different treatments and therapies available, get it adopted, and we may need specific guidelines for circumstances that exist there as compared to the United States or Canada, for instance. Patients were full voting members and went through lots of comments. So this is kind of the timeline. We've been working on this for a couple of years now, just from project approval through the scoping survey. The panels met twice with data reviews and systematic reviews in between. We had public comment, and here we are right now on the cusp of publication. So where are we going with this? Well, I'm going to go through a couple of the diagnostic one of the diagnostic recommendations, two of the treatment recommendations. There are actually a total of, I think, about 15 recommendations across each of the guidelines. So these are just essentially 3 or 4 of them, but there's a lot more you'll see. So our first question really was, in patients who have an abnormal initial VWD screen, and we suspect that they have type 1, where should we put the diagnostic cutoff? We talked about this last year, that there's 30% and 50% as the cutoffs, and 30% was used by the NIH in their panel in 2007. Or should we use what the labs consider to be a low level, which typically is about 50%? And so where we came up with this was that we recommended a level of less than 30. Doesn't matter if you have bleeding phenotype or not. If you bleed and or it doesn't matter if your levels are less than 30, we're going to say that you have VWD. And really, to recognize the fact that there were people between 30 and 50 who had bleeding, but were not given a diagnosis of VWD, we felt that it was important to include that group. So if people were between 30 and 50 and have abnormal bleeding, that is also considered type 1 VWD. And again, this was a strong recommendation with very low certainty in the evidence. And why did we come up with a strong recommendation? Well, and these are some remarks. This goes into kind of the specifics of what tests could be done, particularly the newer tests that are available through the Blood Center of Wisconsin. We should also think about, do people between 30 and 50 have another bleeding disorder? It's possible to inherit more than one. And if you see somebody who's got a level of 45% and has much more severe bleeding than you would expect, think about, is there something else going on? And, some labs may use 52% or 51%, depending on their particular cutoffs in their assays. So we wanted to acknowledge that. Why did we choose this, and why is there the difficulty? Well, the lower your level, the more likely you are to be found to have a genetic mutation. But the von Willebrand factor gene is very big, and not every patient who clearly has low levels and has bleeding really does have a genetic mutation that we can identify. And as you start to get up above 50%, it looks to be that there's some people have mutations even though they have no bleeding, and similar to other people in the general population. When you look at bleeding rates, bleeding kind of happens across the spectrum, although it's much more common the lower your level. So we did try to recognize that there is significant bleeding between 30 and 50, and that some people will have genetic mutations. When we surveyed the panel and did the discussion, we understood that patients place a high value on determining the diagnosis because the diagnosis grants access to care. And we wanted to prioritize not missing people who have VWD, ensuring access to care. And so we were willing to say that there may be people that don't have VWD who we will give this diagnosis to, who won't ever have bleeding and therefore don't need treatment. But we wanted to make sure that everyone who needed treatment had access. We also recognize that the treatments like desmopressin, for instance, will benefit patients with bleeding disorders like a platelet disorder, regardless of if they actually have a von Willebrand factor problem. So a lot of the treatments are helpful. And we also recognized in our surveys that patients understand and are interested in knowing where their levels are, but they wanted clear diagnostic thresholds. So we really wanted to capture everybody and say that 50 and below, we really can consider VWD unless somebody really has absolutely no bleeding with a level of 40%, for instance. And we also recognize that the levels are continuous. How can we say that somebody with 29% is VWD and somebody with 31% isn't, when those are so close to each other and the assays aren't that great? And so we placed a high value on not missing the diagnosis in patients who have bleeding. What we then also went on to say, though, was that this wasn't the end of the answer. we needed to identify some research priorities and understanding detailed outcomes for people between 30 and 60%. There's some data that suggests that levels of 55 or 60 may include people who have VWD. It wasn't clear. It was really just one study that suggested that. So we wanted to understand those levels. We also need to know how well levels correlate with bleeding symptoms. And we also don't have much information about how family members of patients with VWD do in terms of bleeding and procedures. I'm going to move on to prophylaxis under management. And this was previewed at the WFH meeting earlier this year. In patients with VWD, severe and frequent bleeds, and if you notice, we didn't say type 3. We said patients with VWD who have severe and frequent bleeding. So this could include type 1 or type 2 as well. We wanted to ask the question about using prophylaxis routinely. And the recommendation, this is the very first recommendation in management, is that patients with severe and frequent bleeds, we do suggest using long-term prophylaxis. And this brings us in alignment with much of how management of hemophilia is done. But we also recognize this is one of those conditional suggest recommendations as opposed to a strong firm recommendation. And why is that? Well, the evidence showed that if you use regular concentrate prophylaxis, you reduce the risk of bleeding. You also delay the time to somebody's first bleeding event. You reduce nosebleeds. You reduce bleeding episodes, hospitalizations, heavy menstrual bleeding. And what we really only have is a single randomized trial that talks about this. And there was a question of increased bleeding in episodes that lasting more than 2 days. And there was more gastrointestinal bleeding in people who were on prophylaxis. And so this was really hard for us to reconcile in the data. And so there were clear benefits, but there were some potential harms. And so rather than shift and say everyone should really be getting this, we wanted to open up the opportunity for conversations for patients to have directly with their teams about what would be the risk and benefit balance in them personally. And so the themes from this portion of the discussion, most of the patients on the panel discussed that they and their friends and family members and those they know with VWD would likely place a high value on reducing the risk of bleeding, especially if there was improved quality of life. But we also recognize that the value depends on how frequent and severe the bleeds are. You can have two people with severe VWD and one person mainly only bleeds with procedures, whereas somebody with the exact same levels may have frequent nosebleeds, joint bleeds, and you need to individualize therapy. And so some patients may say, I'm willing to do prophylaxis because what I'm going through is so tough right now. While somebody else may say, you know what, I'm fine. I would rather just do on-demand therapy. And so this really highlights shared decision-making with the clinical team. And we also noted variability in the values and preferences amongst individual patients. Even on our panel, they were saying, I really, I have severe bleeding, but I really wouldn't want to do prophy, while somebody else said that they would. So it is really an individualized decision. This also highlighted the importance of making sure that we provided educational materials. And so this is one of those areas in which we will likely be developing decision tools and patient decision aids and educational materials to really highlight what are the pros and cons of each approach. We had low certainty in the evidence that there was an overall benefit, and there's a lot of cost associated with routine prophylaxis. But it's likely to be acceptable and feasible, just like it is routine prophy in patients with hemophilia. And so we thought it would increase access to care by making this recommendation. We had a lot more research priorities for this one. We wanted a large randomized controlled trial to look at prophylaxis, particularly in patients with mucosal type bleeding, use in heavy menstrual bleeding, GI procedures, looking at differences between plasma-derived and recombinant, How well do things like tranexamic acid affect prophylaxis? Do you need to do prophylaxis every third day, or could you get away with every fourth day or once a week in patients who take tranexamic acid? And what about things, medications and infusions that help reduce the likelihood of gastrointestinal bleeding? And so there are other therapies out there that may play a role in the treatment, and how do you actually implement these as well? I'm going to move on in a second here to heavy menstrual bleeding. And this was, to give you an idea, the panels actually prioritized 3 different questions about management of women's health and VWD. And this was because the scoping survey showed that one of the highest priority areas of unmet need was women's health. So we actually cover heavy menstrual bleeding, which we'll talk about here. We also have recommendations around postpartum hemorrhage and neuraxial anesthesia, such as epidurals with labor and delivery. So we're very clear that we have a strong set of guidance to make sure that women with VWD can be safely managed during pregnancy. And so we really talked about, in women with VWD with heavy menstrual bleeding, should we use tranexamic acid, hormonal therapy, or desmopressin? So this, as you can see, is actually 3 comparisons. So there was a lot of back and forth and ranking and evaluation of data. And what we suggest is either using hormonal therapy. You can use a combined hormonal contraception, something containing estrogen and progesterone, or things like the levonorgestrel releasing IUD. Mirena is one brand, for instance, or tranexamic acid over desmopressin. And why is that? Well, this was because the benefits really seem to be with the first 2 therapies. Desmopressin is a valid option and works, but has a lot of side effects associated with it. So that's why it really pushed us. But again, this was a shared decision-making recommendation because we don't really have great evidence. There was a second recommendation that came out of this, and we actually also said, for women who are trying to conceive, obviously you can't use birth control pills with estrogen in it because that will prevent contraception, and you can't use an IUD. And so we actually suggested using tranexamic acid over desmopressin and hormonal therapy because of the need to help provide menstrual bleeding control in women who are trying to become pregnant. And so this was also to say that, you didn't have to do these stepwise. You can actually combine therapies. You can use a combined contraceptive with estrogen. You can use an IUD with tranexamic acid. If you need to use all 3 with desmopressin, you can, especially if you don't really get good control with your first treatment option. We also know that desmopressin isn't very effective in some situations, particularly no effect in type 3, and many patients with type 2 don't really get a great response from it. And we should not be using desmopressin in type 2B. So we wanted to call this out to make sure that there was no inadvertent use of desmopressin in people who would not benefit. And we also recognize that even with your first treatment and the first several menstrual cycles, there's oftentimes heavy bleeding, and you may need to provide additional therapy for the first couple of months until the therapy and the hormonal status balances out. We provided some good practice statements. These are actual, just kind of almost common sense things that you would expect people would do, but it's good to just write it down and say, this is something that people should be considering. And one of this is about multidisciplinary clinics. So many of you know Dr. Stacy Croteau at Boston Children's. She has a combined clinic in adolescent medicine where gynecology is present as well. I've been doing a clinic with some of the gynecologists here at the Brigham as well for very specific issues. We also recognize that particularly use of hormonal therapy and the placement of an IUD requires decisions amongst hematology, gynecology, the patients, family members, depending on age. There's a lot of shared decision making. And there are many other reasons to use hormonal therapy other than just bleeding control and contraception. Think about polycystic ovary syndrome, migraines associated with menstrual cycles. So there's a lot of different reasons to use hormonal therapy that also combine into our decision making. So what do we do that, basically, we also recommended think about iron deficiency and anemia, and you should treat this. There's quality of life data about making sure that iron deficiency anemia is being addressed. Think about standard gynecologic assessment. Make sure there's not a fibroid or a polyp that needs to be addressed that is contributing to the bleeding and could be easily addressed to improve quality of life. And we also think about the fact that there are specific side effects about using hormonal therapy, particularly in women who are obese, women with diabetes, hypertension. And so some of this requires a little bit more nuanced discussion than the guidelines could really get into. We wanted to make sure that there's a high value on the balance of the therapies and ensuring access. And also understanding that we need to make sure there are options for women who want to be able to become pregnant. Some women are told that they cannot become pregnant or they should not deliver and use an epidural with VWD. And we really want to make sure that women can have families and have access to therapies that are appropriate. We identified some research priorities about combined therapies versus single therapy. We wanted to ask for a specific study on patient preferences and values around contraceptive methods. We have that in other areas, but not specifically surveys of VWD patients. And also understanding a little bit more about the hormonal IUD acceptability, what are spotting rates and risks associated with the placement. So I'm going to kind of go into questions here. I've thrown a lot of information at everybody. I'm going to go through some of the questions that we received in advance, and hopefully I've answered many of these questions through this session, but I'll go through it, summarize it, and then we have the questions coming in through the chat. So the first question was, what are the current parameters for diagnosis of VWD? As was mentioned, right now, up until the publication of these guidelines next month, 30%, less than 30% has been used as the traditional cutoff, and 30 to 50 has been labeled low von Willebrand factor. Not a disorder in itself, but a risk factor for bleeding. We are changing that to say that under 50 with bleeding is VWD. Anybody under 30 is VWD. And so there will be some people between 30 and 50 who have absolutely no bleeding. And we shouldn't give them a diagnosis of a disorder if they don't have bleeding that needs to be treated. Testing for VWD is complicated and sensitive. What is being done to simplify diagnosis? In the new guidelines that come out, we're actually having a flow chart that goes through and it's labeled with the questions and the recommendations. Many centers are starting to do more algorithmic approaches. We're trying to encourage labs to have reflex testing if somebody is low, moving to the next step without requiring people coming in and getting extra blood draws. We also provide some guidance. I believe it's the National Hemophilia Foundation just recently published some guidelines on how to draw the tests. When's the timing of when this should be done? So we reference those and talk about those in our guideline. Is there updated information on the use of genetic testing? So this is a really tough question, and it's one of the best questions that the panel tried to consider. I didn't go too much into it, but we actually have several questions about using genetic testing and what is its role, particularly in type 2 VWD, because that seems to be one of the hardest areas to get a specific subtyping done properly. What I think a lot of people don't understand is that the von Willebrand factor gene is very big. Amongst the genes, it's one of the largest proteins that we have that we sequence. And so there's a lot of areas in which there are genetic variation that actually doesn't cause a problem. So it's very easy to find differences between people. But do those differences actually cause problems is the harder part to sort out. So we have certain genetic tests for the VWF gene that are helpful. We do highlight this in the guideline about using it as compared to things like factor VIII binding, ristocetin-induced platelet aggregation, and use of multimer analysis, and what are the pros and cons of each approach. So we are providing some guidance about genetic testing. How do you go about and what age is most accurate? Well, this is also a really tough question. Timing matters. So in kids, it's really hard to get a blood draw. And Caitlin can probably talk about this as well, that, you know, we have a hard time getting blood draws on kids. And if a kid, you get kind of the one stick approach. And if a very young child starts crying and there's multiple sticks to try to get it, the von Willebrand factor levels start to go up very quickly, so you may obscure a diagnosis. We also try to avoid drawing levels during pregnancy because the levels are much higher during pregnancy than they are at baseline. They can also differ depending on if it's done in a local lab versus one that's sent out halfway across the country. So we also provide some guidance in the guidelines that you'll see about what are some situations that you should think about if you're doing testing. In terms of treatment and management questions that we got in advance, what are some emerging therapies and alternatives? What I would say, and any new treatments on the horizon that don't include infusions. So right now, our main therapies for treatment include von Willebrand factor concentrate, both plasma-derived and recombinant. There's the use of desmopressin to make somebody's body release more of its own von Willebrand factor. That can be given, the infusion, the concentrate is infusion. Desmopressin can be given intravenously. There's a whole set of questions about stymate coming up, but we used to be able to give it intranasally. You can give it subcutaneously as an injection right under the skin. This particularly works well in kids, so there's some data supporting that use. Not necessarily a new treatment, but one that I think is underutilized is tranexamic acid. A pill, also available as IV for in the hospital, but we have a pill medication that really is a great adjunct regardless of the type of bleeding disorder someone has. Some other therapies that are out there, there's stuff in very early clinical trials. We have no idea whether or not any of it is going to show efficacy even in the animal models that are being used, but my hope is that we'll get there soon. Recommendations for treating somebody with prophy versus on demand. As you can see, we have that recommendation. So really, this comes down to shared decision making with, if someone is having severe and frequent bleeds, it's worth considering a trial of prophylaxis to see if they do have improvement in the bleeding and quality of life. How can we learn to self-infuse to avoid going into infusion clinic? Well, I think this is certainly where NEHA comes into help as a resource. There are lots of ways to learn how to self-infuse, and many of our patients do it at home. I have one patient who needs regular infusions for a different bleeding issue, and doing the whole process is much more complicated for that particular infusion. So there's actually a visiting nurse set up to come to the house once a month to provide the long-term therapies. But there's great ways to learn how to self-infuse. So make sure you ask your Hemophilia Treatment Center and talk to the team at NEHA. I loved this question. Given the progress with CRISPR for sickle cell, how likely is that CRISPR will also be used to treat VWD? And so for those of you who don't know what CRISPR is, this is a gene editing technology that has been designed. And so the Nobel Prize in Medicine was actually awarded this year to the team that had developed CRISPR. It was a little bit controversial because they left out the team at MIT and Harvard who actually showed that it worked outside of bacteria. But the person in California had done her PhD work here. So there's still a connection to the Boston area for CRISPR technology. sickle cell and VWD are incredibly different in terms of their genetics. Sickle cell, you can carry the trait and not have any difficulty long term. And sickle cell is due to a single letter change in the gene. Whereas von Willebrand disease, there are a couple hundred right now genetic changes that have been associated with VWD. So it is a lot easier in many ways to try to fix the sickle cell gene. And even with that, it's being difficult, and the trials are being done, and we're very hopeful. But CRISPR, I think, has a long way to go. But there's a lot of interesting discussions about how gene editing therapy is going to work in hemophilia and in VWD. So when do you treat with factor for nosebleeds or menstruation? So I think this is about using on-demand therapy. It really depends on the frequency. You can also consider using factor. And I oftentimes will use, I recommend tranexamic acid for the first couple of days of menstrual bleeding if somebody's having heavy menstrual bleeding, because it can really help without needing to use factor directly. What recommendations do you have for managing school-age males with VWD? The interpretation I took on this question was about, about maybe contact sports, for instance. So I think this actually applies both to men and women, because contact sports are an important part of staying active. Depending on severity, this may be something that somebody gets treated with prophylaxis right before they go out and play a sport. And again, this is something that's individualized for each person as to what is best for them. How do you manage increased bleeding with intestines? So there is some information about von Willebrand factor may affect a different protein in the blood that then, if you don't have von Willebrand factor, this other protein causes issues with bleeding in the GI tract. That's one of those research priorities, those anti-angiogenic therapies. There are some patients, if you start to treat them with routine factor, it will actually improve the GI bleeding and make those anatomic spots go away. So that's again on a case-by-case basis, but we do need research in that area. And how do we recommend seasonal energy and hormone shifts in women post-menstruation? And so we can consider using hormonal therapy. Tranexamic acid is helpful if there is bleeding. And so physical activity is oftentimes one of the best options for helping with energy overall. It seems counterintuitive, but the more active you are, the better you feel. There's some questions about stymate here. What about the stymate recall? For those of you who don't know, stymate was recalled due to an issue that some lots were more potent, higher concentration, so the dose that would be delivered would be higher. We are not really sure when we're going to see it back. We've been told not to expect until mid to late 2021 at the earliest, probably. There was one report I saw that potentially 2022. I think COVID has really kind of affected this for a lot of the production. Personally, a few of my patients, I've had to have them come in to get desmopressin infusions prior to colonoscopy, tooth extraction. And the good thing is that desmopressin infusions, they can last a couple of hours. So depending on what you're doing, they can come get it infused and then drive the 5-10 minutes to their dentist's office, for instance. Other treatments other than stymate, I use a lot of tranexamic acid, particularly for mucocutaneous bleeding, and that stymate can help with that. So again, this is individualized. So speak with your hemophilia treatment team. And then lastly, some questions. How about COVID impacting someone with bleeding disorders? Fortunately, we have not seen much in the way of issues. There was concern, and the World Federation of Hemophilia very quickly did some work and issued guidance on understanding, could COVID be transmitted through plasma-derived therapies? And fortunately, the process that the plasma-derived therapies go through really leads to viral inactivation. And we have good data on other coronaviruses, because this particular coronavirus is in a family of the other viruses that we've dealt with for years that cause common cold and other infections. And so we know that the viral inactivation process works. And the main thing has been an issue with access to therapy. We want to make sure people come into the emergency room if they're having severe bleeding. Do not delay care. So that's really important. Precautions with a newborn with possible VWD. So this really requires a conversation between the hemophilia team, the obstetricians. We tend to, if we have any concern, we'll say, you know, don't do mechanical assistance with delivery. Assume that the baby has VWD until you get testing otherwise. And so if everybody thinks and comes to this as a perspective of the baby likely has VWD, then everybody is a little bit more careful in every single decision making. Postpartum bleeding, tranexamic acid is fantastic. We have good data for it in general populations, but we need more data in VWD, but I do use it. And inhibitor development. Fortunately, inhibitor development is very rare. I have not seen inhibitor development due to prophy from humate. And I've asked many of my colleagues that do VWD here and in other countries, and nobody has seen it, although there are a few reports in the literature about it. So we've been very fortunate as compared to the concerns for inhibitor development in patients with hemophilia. So really it's severe type 3 that we worry about the potential inhibitor development the most. So I'm going to end there, and then Caitlin can join me and we can tag team some of these questions.
All right. Am I unmuted? Yes. Thank you so much. That was such a great presentation. And I tried to streamline as many of the questions as possible so that we can get to everyone, but there were a lot that were coming in and they were all really good. So Rich, how far can we go over? You cut us off when we.
Yeah, I say let's go for a solid 10 minutes and see what you know, rapid fire here. But I think this is really important. So if we go further, it's totally okay.
Okay. So some of the questions, so one of the things I did want to point out as far as like for tranexamic acid, I think I talked about last year too, is that in pediatrics, it is a little bit challenging for tranexamic acid because of the dosing and that it only comes in a tablet. So a lot of times for pediatrics, Amicar, for someone that can't swallow pills, a lot of times Amicar is used more so. And then to answer some of the home infusion help, a lot of specialty pharmacies or your HTC can do teaching, NEHA can do teaching, and a lot of specialty pharmacies contract with the home infusion companies that can do home infusion teaching as well. All right, so one of the first questions that came in was about diet, and does a person's diet affect von Willebrand disease? I'm asking because there's different foods that have vitamin K, and vitamin K promotes blood clotting. So you can answer it.
The short version is we recommend a balanced diet. And so if you're not getting enough vitamin K, it can exacerbate bleeding. But too much vitamin K will not cause blood clots. So it only puts anybody to their baseline level. It doesn't overshoot in the other direction as far as we know.
Right. And then, a copy of the slides. So Rich is recording this so everyone can get a copy of the slides. So as far as heavy bleeds, so this is talking about for heavy menstrual bleeding. What if you're still having heavy bleeds with an IUD? Or if an IUD is not making it better with heavy periods?
Yeah, so particularly in the first few months after an IUD is placed, there's oftentimes continued heavy menstrual bleeding. that is one of those time periods where I will say, you know, tranexamic acid. And honestly, because sometimes there can be a little bit of a delay in getting the IUD placed, I'll oftentimes start tranexamic acid before the gynecologist can then, you know, in a couple of weeks, get somebody in for their IUD. We will use desmopressin as well if somebody's having it. And I oftentimes will say, start the tranexamic acid the first day of your cycle and see if it shortens it. And if you're still having heavy bleeding on day 2 or 3, in spite of tranexamic acid and the IUD, a dose of desmopressin if you have your stymate at home, obviously in the certain circumstances that we're in, a little bit tougher.
And depending too, as you were saying, you have a combined, a lot of HTCs are having these combined women bleeding disorder with a GYN or an adolescent provider involved, and getting their input on too, because I've had other patients that have started with an IUD and also concomitantly use a hormone and slowly taper it down until there's no bleeding. And some people might even need both. So it's kind of, it's the shared decision-making, like you were saying, that's really important, and there's no one size fits all for management. Unfortunately, it's a very complicated bleeding tendency. It's another one. So if a person has, so there were lots of questions about platelets and von Willebrand disease. And there seems to be a large percentage of people who have both von Willebrand disease diagnosis and platelet storage pool deficiency. And how can we address that? I want to first start, I think there are a lot of people that, like when I started in my practice, that were given the diagnosis of von Willebrand disease at an early age and rechecking levels had been normal. And then I went along to test their platelet aggregation testing and then realized that, oh, you actually have a platelet aggregation disorder, not necessarily von Willebrand disease. And it depends. So von Willebrand disease is the most common. So most times when people are being referred to us, someone's already done a von Willebrand testing. And so it's really just, and not all HTCs or not all hospitals have platelet aggregation testing. And so that's one piece of the question. The other thing is that there are just the relationship between platelets and von Willebrand disease. It's the same bleeding tendencies and it's the same treatment too. So there are sometimes misdiagnosis or even just combined. There's type 2B von Willebrand disease, there's platelet type von Willebrand disease, there's lots of different relationships between platelets and von Willebrand binding, which is why there is such so many overlaps. Do you want to add to that?
Yeah, I think that's a great kind of example of why there's so much confusion. And the von Willebrand factor can come from the lining of the blood cells, but platelets actually carry their own von Willebrand factor. And we know very little about how platelet-derived von Willebrand factor contributes and what is the role of the two different proteins. Are they different and what do they do differently? So there's still a lot to come in platelets and how they interact.
And since we're staying on the platelet topic, we'll go. So is there, let's see, atypical, so where can we get information about specific types of von Willebrand disease? I think I always refer to patient advocacy group and just looking on PubMed for recent articles and things like that for more detailed about a specific type, like a type 2B.
Yeah, the kind of the great places I send people. So National Hemophilia Foundation, and also the World Federation of Hemophilia. They've got tons of educational materials and about all the different bleeding disorders. And WFH has made a very big push that it is a resource for all living with bleeding. And so, and as part of the guidelines, there's going to be a lot more information, pocket guides for clinicians that are going to come out and kind of talk about these different ones and these different types of how they actually differ from each other.
And then as far as, so are there current studies going on for that platelet issues? Not that I'm aware of. As far as, I guess, is the question looking at how many people are diagnosed with both platelet aggregation disorders and von Willebrand disease. there's lots of ongoing studies with platelet specifics and von Willebrand specifics, but the one study that's out there right now that's ongoing is ATHEN-9, which is specifically dedicated to von Willebrand disease, and now ATHEN-10, or the American Thrombosis and Hemostasis Network, that coordinates a lot of our research studies through HTCs, and ATHEN-10 is on rare diseases and platelet disorders, includes genetic testing on platelet disorders, and then ATHEN-9 for von Willebrand testing, and offers genetic testing and also all of those other fancier tests through Versity, the old blood center Wisconsin, like GP1BM and these other fancier tests. The other question, so people are saying, will all of our hematologists and healthcare providers know about these new guidelines? And is there a chance people will be undiagnosed if they're not showing outward symptoms? I'll let you take that one.
The second part's easier to answer than the first. So the second part about people being undiagnosed, we actually have one question in the diagnosis manuscript about patients who carry a diagnosis of VWD based on historic levels, but then subsequently due to aging, their levels may have come up, or their levels are now normal. And should we reconsider the diagnosis, or should we remove it? And that seems a little bit odd that we asked a question about that, but that's what happens in practice. Some people just have it taken off their charts. And what we really felt was we needed to understand about that reconsideration process and providing some guidance. So we wanted to provide some education in the guideline that levels do go up as we age, and that somebody still genetically carries VWD, even though their levels may put them into a category where they don't have bleeding in their 50s and 60s like they did in their 20s and 30s. But we also recognize that a lot of people were given a diagnosis of VWD that in fact do not have it. So we wanted to make sure that people are thoughtful about going through a reevaluation, considering are there platelet disorders. So that's outlined in the guidelines. How do you actually get these guidelines out to everybody? Basically by doing exactly what I'm doing, talking about it to people. There's a huge implementation and rollout that's coming with this. We've been meeting with the communication teams at all 4 organizations. So you're gonna see a lot of press coming out about this as soon as it's published. There's press releases, there's webinars. So in the spring, I can't give you specific names yet because it's not public, but one of the patients on the panel, one of my pediatric colleagues and I will be speaking on behalf of the CDC in February in a global webinar about the guidelines and how they were developed. And so that'll be free and open to everybody, but it's also important for all of you to bring this up with your teams and say, you know what, I heard there are new guidelines. Is there anything in it that applies to me or how I'm being managed or what I should be doing? Just prompting the conversation is a good piece because, again, clinicians are very busy. The physicians and nurses that take care of you want to do the right thing, but you know, it always helps when somebody says, hey, we just heard about these new guidelines. So what can we do to work together on this? So that's the harder part to actually do than just the thinking about making the guidelines.
And I think it may actually be the opposite, that I think there's a lot of, because the National Heart, Lung, and Blood Institute that was our guidelines before that had that 30 to 50 range characterized as low von Willebrand, I think it will be the opposite, that there are a lot of people that fall in that category that will then say, well, now we're calling you type 1 for this reason and based on these guidelines. So if anything, it would be, but I think management would probably be similar in that if people don't have symptoms, which is whether we call someone low von Willebrand versus type 1, if there are bleeding tendencies, then we still follow people if they have low von Willebrand or type 1 because they're bleeding, and we can offer treatment. So should someone then ask about genetic testing to confirm past diagnosis? I think, like was mentioned, it's very challenging, and there are a lot of mutations that aren't known or may not be identified, and it's more the severe types that may have a genetic mutation that can be identified. But a lot of people in that type 1 range, it's harder to actually identify a mutation. All right, I want to make sure I get to everything on here. There were other.
Maybe a couple more questions, Caitlin.
Yeah. All right, the diet. All right, the COVID question. So as far as COVID connection to VWD, the thing that did come out that was interesting was more that people with type O blood who categorically have lower levels of von Willebrand disease may be less likely to have a more severe type of corona, like COVID, less likely to have more complicated symptoms when infected with coronavirus, just because coronavirus is very prothrombotic and has a lot of other clotting tendencies. So if you have lower levels of von Willebrand factor, then you may be less likely to have those prothrombotic tendencies, is really what we know. What else do you want to comment on?
Yeah, it's a tough thing, because think about this. Every single expert on COVID that exists has been learning about COVID in the last 11 and a half months, because we had no idea until it was reported on December 31st. So there's a lot of on the fly understanding and learning going on. We know that COVID causes inflammation. We also know that blood vessels release von Willebrand factor in response to inflammation. So we see very high VWF levels in patients with COVID. There was a genetic study that tried to map and found that blood type linked to severity. This is one of the problems with epidemiology studies, is that you're looking at things that are far apart and trying to get a correlation between them. In a subsequent study, that seemed to disappear. So it is not entirely clear about this blood type piece and VWF levels. I've had conversations with different researchers, and I said, maybe we should, there's a registry study trying to look at patients who have VWD who end up, this is through the American Society of Hematology, with VWD who then get COVID to see if they have less severe courses. It's tough to correlate this data, but we adjust and react to all the studies as they come out. So my hope is that it's less severe because people run lower levels, but I wouldn't be afraid to treat somebody with concentrate, either plasma-derived or recombinant, if they needed it, to treat a bleed even during COVID.
And it's not taking into factor von Willebrand patients that have asthma or overweight or have other comorbidities, immune deficiencies and stuff. Another question I did want to get, because it was asked a few times, was related to von Willebrand disease and migraines. And have there been any studies specifically related to von Willebrand disease and migraines? You can go ahead.
Caitlin, I actually don't know much about. I haven't seen much in the literature that's definitive. I've seen an association with it, but I don't know. Have you seen anything on the ped side?
No, so I was actually, just as the question was coming in, doing a quick lit search, and ironically, the only article that I came up with was looking at people that have higher levels of von Willebrand factor may have a correlation with having an increased incidence of migraines, saying that maybe people with von Willebrand disease are less likely to have migraines, but I didn't get a chance to actually look at how good this study was, so that doesn't say anything. And also, I think with migraines and everything with von Willebrand disease, if you are losing blood and you are anemic or you are iron deficient, then one of the main symptoms of iron deficiency and anemia is a headache and could be a migraine. So I think in that sense, if someone's having migraines or more predisposed to migraines, it may be related to blood loss and anemia.
There's a lot we don't know about VWD and all of these other things and how they all interplay. So I told you I'd be honest at the beginning if we didn't know something.
Right. All right, so lots of other questions to type 2. Rich, you want me to wrap it up now?
Yeah, let's go with one more. I mean, I could listen to this the whole day. I mean, here, but I maybe one more question, and then there are breakouts and wrap sessions, and we can always submit other questions if they haven't been answered.
Okay, so I think a lot of them are, Carol, I'm trying to get to all of yours. Type 2s with defective von Willebrand disease be at greater risk. I think it's the same thing. We still don't know enough about COVID with all of this. There's nothing to say that people with von Willebrand disease are any more at risk for getting coronavirus or.
Caitlin, can I ask a question on that one? The vaccine is apparently on the horizon. How do you think that that vaccine will affect people with VWD if it's supposed to be a clotting, apparently COVID has something to do with clots, right? So how do you think that vaccine put into our body will affect us?
So the vaccine would not be a live vaccine, so you wouldn't be infected with you wouldn't be injected with the disease. It's to basically have your body mount the antibody response so that you remember that virus and that you wouldn't get it, similar to a flu vaccine or any of the other vaccines that you receive. It's when people are actually infected with the disease and what it does to the body and the systems is what makes it prothrombotic. But the actual vaccine, I have not heard anything about it being prothrombotic and should not be prothrombotic, just like other vaccines. Would you agree?
Yeah, I would agree. I think I'm one of the trial participants, in the vaccine trials here through the Brigham, and many of my colleagues and their patients that have been in it. It'll be interesting to see when the data come out because they included a wide variety of people. So there may be a subset of people with bleeding disorders who are in the trial. We'll just have to wait and see. I think the bigger concern for discussion, and NHF's Medical and Scientific Advisory Committee has been trying to think about this, and along with the European Hemophilia Association, about the fact that these injections are intramuscular. And so we avoid deep intramuscular injections. In a lot of our patients, we talk about subcutaneous and vaccination. So it may require that we think about treating somebody and giving them a infusion of desmopressin beforehand or factor concentrate, depending on how low their levels are. So we have to wait and see how that's going to come out of the scientific advisory committees for what they're going to recommend, how we roll out vaccination in bleeding disorder patients.
I would love to take more questions, but I want to stay on time here. Dr. Connell, Caitlin, thank you so much for spending your morning with us and giving this incredible overview of VWD, the new guidelines, answering all these questions. You guys did an incredible job. I agree with one of the comments. I'm not sure you saw this, Dr. Connell, but someone said that they've never in a virtual world seen a presentation like this where all the questions were answered in the presentation and it flowed. So kudos to the both of you. Thank you for spending time with us, and we really appreciate it.
And any of the questions that we didn't get a chance to answer, I know some of them are kind of more personal questions, so please reach out to your regular hematology provider so that you can address some of the questions with them.
Absolutely.
Thank you for having us.
Thank you.
Thank you, guys. And I appreciate you both using your Niha mug and coffee mug there. So kudos. Nice. Awesome. Well, thank you, guys. I really appreciate it, and enjoy the rest of your weekend. All right. So welcome back, everyone. Now it's time for a commercial break. So I'm going to spotlight Michael, who is going to be our MC for the commercial break.
Well, thank you very much, Rich. And you know it's true, is that we have some great folks who have helped to make this weekend possible. So taking a page from the song, I'd love to switch over, and as we stretch our arms and limbs for maybe a minute and get ourselves energized as we head into the next segment. So up on deck, we've got Megan Carty from CSL Behring, and I've also got Tony Bassa from Octapharma, and we're going to take a quick commercial break and ask them a couple of questions to learn a little bit more about their organizations and companies and what they do and how they can help us all. So I will start with ladies first. Megan. Going to turn the music down, even though I like that.
I like the music.
I know. testing songs before, and I'm not going to lie, it was pretty good. So, Megan, thank you for being with us, and for both Megan and Tony. I'm going to ask you to introduce yourself real quick. Tell us a little bit about your connection, and then a 30-second quick commercial, a little bit about your company and what you've got to offer. And of course, the most important question to kick us off too, what's your favorite holiday tradition?
Perfect. Do you want me to start, Michael?
Yeah, that would be great. Thank you.
Okay, so hi everybody. I'm Megan Carty with CSL Behring. CSL, we've got products for hemophilia B. We have Idelvion. We have Afstilla for hemophilia A, and we have HumAP for VWD. Website would be cslbehring.com. And most importantly, the holiday tradition. It was kind of hard to think of this one, but I would say I love decorating for Christmas. And we'd usually do that. Typically, the house will explode into Christmas the day after Thanksgiving, but I think we may do it tomorrow.
Good, wonderful, even better.
You know, just seeing those lights just cheers you up.
I hear you. We already wrapped the banisters, so we're ready to go with the DiGranzello household.
Awesome.
Yeah, I put that in our marriage contract that it gets wrapped mid-November and it comes off sometime in mid-October. So there's really only a month of there.
Awesome.
Well, thank you, Megan, very much. And you'll have to make sure that we all see some pictures of the house decorated, or at least a tree picture. Yes. But thank you, and thanks CSL very much for your continued support, as always, of our programs and services at NEHA. So thank you. And moving right along, I'm going to hop over to Tony. Spotlight's on you, bud. I think you're still on mute, so just check that real quick. Yep. But Tony, we're so appreciative of you and Octapharma for taking a few minutes to spend with us. So Tony, what's your favorite holiday tradition? And tell us a little bit quick about Octapharma.
All right, well, Tony Besa, our son has VWD 2A. I'm a patient educator for Octapharma. We offer Willate for VWD patients, and also it has been also approved for hemophilia A. But check with your doctor just to make sure. Favorite holiday? I don't think tradition, don't have one. I'm a Scrooge at Christmas time, so I like to say humbug while the wife walks around singing Christmas songs, and she's already started. The only other thing I'd like to say is thank you for letting us come today and talk to everybody. And I'm going to give a plug. If you go onto YouTube and look up Take One Day at a Time and Live, you will actually see our family story on there for Octapharma. So please go take a look at it. If you have any questions, always feel free to reach out to us. Thank you. Oh, and everybody be safe out there because the numbers are going up.
Yes. Wash your hands, mask up. Thank you very much, Tony. Very much appreciate your support and Octapharma and of course your family. And sounds like we need to get you a quick sleigh ride. So if anyone's got a snowmaker and a sleigh, head over to Tony and give him a ride around the house.
No, don't need it. Don't need it.
Well, maybe I'll have to queue up some Barbra Streisand jingle bells to take us into the next section. But let me see how quickly I can find that. Anyway, so thank you guys both very much to CSL and Octapharma for helping us out and supporting our great VWD retreat that we're doing this weekend. So with that said, we're going to toss, moving right along, going to toss right into the breakout rooms. It looks like we've got 3 of them. One is putting yourself out there. One is taking a proactive approach to aging with VWD. And one of them is going to the ER. So I believe Sarah is going to do the technical on this. And I think Rich might be sending us in there. So I'll toss to Rich.
Great, thank you. Commercial break, MDG. We appreciate it. So I'm going to share my screen. So here are the 3 breakout rooms. Breakout number 1 is Put Yourself Out There, Advocating for Bleeding Disorders by Takeda. Breakout number 2 is Taking a Proactive Approach to Aging with VWD, CSL Behring. And breakout 3 is Managing the Emergency Room Octapharma. So the way that this works, if you haven't done it before, you pre-select via email which one you want it to be in. So Sarah will press a button and you will go into these breakout rooms. If you do not go into a breakout room, no fret, stay in the main session and Sarah will ask you which one you want to go into. So of course there's technology glitches. I promise you won't end up on Pluto. And if you do, we will bring you back home. But you will go into 1, 2, 3. So let me ask Sarah, are we ready to make magic happen?
Yes, yeah, everyone, thank you, Rich. Everyone who pre-selected a breakout room, you have been assigned to that room. So look for a pop-up on your screen that asks you to move to that room. For anyone who has the latest version of Zoom downloaded and you didn't pre-select a room, you should be able to choose one. And then the third option is if you get no pop-ups, as Rich said, you can stay in this main room. Feel free to put the number session, so just 1, 2, or 3 in the chat, and I'll go ahead and move you. When I move you, I will say your name. So I'll say Rich has moved, and you should look for a pop-up. So that's how it'll work. Awesome. But Rich, I'm ready to go ahead and open up all the rooms.